Welcome to today's iReview session. My name is Yejun Hong, a second-year medical student at the University of Calgary. Our team here will present to you today about AAION, Arteritic Anterior Ischemic Optic Neuropathy, as a link between ophthalmology and emergency medicine. The field of ophthalmology and emergency medicine is quite intimate. Around 2 million visits to the emergency department every year in the US are from ophthalmic conditions. And the topic we are going to cover today, giant cell arteritis, which is an arteritic AION, is an emergency. This is one of the reasons why people go to the ED. This unique and emergent ophthalmic condition, known as giant cell arteritis, is also associated with other medical fields as well. Polymyalgia rheumatica, which is a disease in rheumatology, is also associated with scalp tenderness and temporal pain, and indicated with vasculitis known as giant cell arteritis. Another link can be drawn between ophthalmology and neurology. GCA causes arteritic anterior ischemic optic neuropathy, or AAION. This is essentially an impairment in the optic nerve. So this is a disease that's quite mouthful. What is an AAION? So it's an arteritic category. There's also a non-arteritic AAION, but in this case it's an arteritic category of the ischemic infarction of the anterior optic nerve. Right? So there are vasculature feeding the optic nerve as well, and the anterior segment is suffering from ischemia. And there's an occlusion of the posterior ciliary circulation, which feeds the anterior optic nerve, and this is behind the lamina cribrosa of the optic disc. The arteritic classification is due to the giant cell arteritis that occurs. So with giant cell arteritis or temporal arteritis, you'll get scalp tenderness, the jaw claudication or tiredness from using the jaw repeatedly over a long period of time, and also temporal pain. Let's take a look at the vasculature where AAION and the GCA can occur. So there's the internal carotid artery leading from the heart all the way up into the neck and into the head. This turns into the temporal artery as it crosses the temporal area of the head, which then branches out into an ophthalmic artery and then to the posterior ciliary arteries that feed the optic nerve. People at risk of AAION are patients over the age of 55 or patients with polymyalgia rheumatica. Polymyalgia rheumatica is an inflammatory disorder that causes widespread aching, stiffness, and flu-like symptoms. And the most common presentation of polymyalgia rheumatica is the pain and stiffness in the shoulder muscles, as well as the necks and the hips, and also the morning stiffness. A main symptom of AAION that we should note is dyschromatopsia, or the loss of color vision. However, because AAION is often associated with giant cell arteritis, we can look for the presentations and indicators of GCA to also have suspicion for AAION. The classic triad of GCA presents with first the scalp tenderness, or the pain upon touching the scalp, especially the temporal sides, jaw claudication, so the tiring of the jaw after a patient talks for a long time or eats a big meal, or headache along the temporal sides. GCA, because it is an inflammatory condition, can present with B symptoms as well, such as fever and weight loss. It also presents with diplopia, or double vision, as well as amaurosis fugax history, which is a fancy term for episodic vision loss. Those symptoms I have mentioned are all associated with GCA. AAION can also be associated with polymyalgia rheumatica, which is a rheumatic disorder. And to check for that, we ask the patient and check if they can extend their arms beyond 90 degrees. If there's joint pain or even inability to do that, there is a good chance that the patient may have polymyalgia rheumatica. And this should raise your suspicions toward AAION as well. With AAION testing visual field, you'll notice that the patient often has central or altitudinal visual field defect. Upon observing the pupils, the patient will have an RAPD, or a relative afferent pupillary defect. This can be confirmed by a swinging flashlight test. While normally on perception of light and stimulation of the optic nerve after that, the pupils will constrict in response. However, if the light sensing system, the cranial nerve 2, is impaired in the other eye, upon shining light at that eye, the fellow eye will receive less light in comparison. This will result in dilation of the pupils instead of the maintenance of constriction. When observing the back of the eye with fundoscopy, there may be swollen optic disc as well as swollen and tender temporal artery upon physical exam. On back to fundoscopy, you'll also find cotton wool spots indicating ischemia, and in the late stage, you'll find optic disc cupping and elevation. In this eyepiece, we have learned the links and the epidemiology, symptoms, and signs of arteritic anterior ischemic optic neuropathy. In the next eyepiece, we will learn the differential diagnoses, history and physical exam, investigations, treatment, and prognosis of AAION.